Hello and welcome to a Health Podyssey. I'm your host, Alan Weil. High-deductible health plans, or HDHPs, have been around for decades, but they grew dramatically at the start of the 21st century. Conceived of as a way to make healthcare consumers more cost-conscious, they do so by, as the name implies, placing a large share of the financial burden of healthcare on the consumer at the time they need care. Now, for advocates of HDHPs, a critical companion to the insurance plan is an HSA, or health savings account. This is a tax-favored savings mechanism that the consumer can dip into when they need healthcare service, but grows with interest if it isn't used. As it turns out, many people with high-deductible health plans don't have HSAs, so they're left to manage their cost-sharing out of their income and savings. All of these policies play out in the context of income and wealth inequities in the United States, where Black and Hispanic families have faced long-standing barriers to building wealth and earning income at the same levels as white families. So how does the HDHP design interact with racial and ethnic inequality? That's the topic of today's episode of A Health Podyssey. I'm here with Naomi Zewde, Assistant Professor in the Department of Health Policy and Management in the UCLA Fielding School of Public Health. Zewde and co-authors published a paper in the October 2024 issue of Health Affairs that looked at how high-deductible health insurance interacts with racial and ethnic wealth disparities. We'll discuss their findings in today's episode. Dr. Zewde, welcome to the program.
Thank you so much for having me.
Let's start our conversation, if we could, with just a little bit more context than I provided in the introduction. Can you tell our listeners a little bit more about what an HDHP is, but also how common they are and how they do or don't work with these health savings accounts that I mentioned?
Sure. So I'm glad you're asking actually what a HDHP is, because research shows a lot of people don't know. My own sister, extremely highly educated, got her first job, and she was asking me about her health plans, and she's like, so what's a deductible? Because it kind of sounds like a coupon. I'm like, no, it's not. So a high deductible health plan, not at all. It's for them. Yeah. So you enroll in this insurance plan, you pay your monthly premium, and then for a lot of consumers, you're going to be paying for all of your care out of pocket, or at least up to the deductible before your plan starts kicking in. Some kinds of care are going to be exempt, things like preventative care under the Affordable Care Act, for example, maybe a preferred in-network tier. So basically the places that your plan might want to steer you towards. Officially, the definition of a high-deductible health plan is at $1,300 for single coverage, $3,200 for family under the IRS rules for 2024. And the reason that the IRS has a definition here is because it's associated with these health savings accounts. HSAs, and there are different kinds of health savings accounts, though the HSA is the most common. We examine all of them. They're just really highly tax-favored accounts that you can use only if you have a high deductible health plan. So another researcher, Tony Lasasso at UIC, calls it an IRA plus. I think that's a great way to think about it. So you can contribute pre-tax dollars. It's invested on your behalf, and that growth is untaxed as well. You can withdraw actually 65 plus for any reason, and it'll be taxed at your retirement income bracket, or you can withdraw it pre-65 for healthcare. There's no penalty, there's no tax. So it's useful to have the potential rollover as an incentive to not use unnecessary care. And it's also useful to have if you need to pay for a lot of healthcare out of pocket.
So what you're describing is a health plan where you have a potentially very large upfront payment if you need healthcare services, larger than sort of your standard deductible. Those have gone up as well. And if you're fortunate enough to be able to dip into one of these savings accounts, that can pay for those services. But if you don't have one, then you've got a lot that you've got to come up with. Your study focuses on the implications of these plans, or I should say the intersection of these plans with income and wealth disparities. Now, the topic of income and wealth disparities between white families and Black and Hispanic families has been covered for some time. But again, I'm not sure all of our listeners have that background. So maybe if you could just, again, before we get into your research findings, just set the stage here. What do we know about the disparities in income and the disparities in wealth between white families and Black and Hispanic families?
First, income inequality and wealth inequality are really two distinct things. Income inequality has been narrowing since the civil rights era, along with educational disparities. Basically, since Black Americans have not been explicitly barred from occupying, these professions in these educational institutions. Wealth, though, is intergenerational. And not just at bequest, but it's like across the life course. And there just hasn't been that many generations since the civil rights era for wealth to have, for people to have accumulated and transmitted this wealth across generations. So nationwide, the median Black household as of 2022 has about $45,000 in net worth, and that includes home equity, retirement, everything. The median white household has $285,000 in net worth. So by contrast, median white household has about $77,000 in income versus $53,000 in income for Black households. So Black households have about 70% of the income and only about 15% of the wealth of white households, but incidentally have actually higher savings rates as a percentage of income. So it's really just this generational kind of problem. So what we wanted to know is, what is that disparity like for the privately insured? It's a disproportionately small share of Black households that have private insurance, and it's a disproportionately well-off slice of that population. So we wanted to know, is it still going to be present? And we find very much so. And also, as we suspected, it's there all the way across the income distribution. So at the same levels of income, white households have, 50, 100, 350% more in assets or financial assets relative to the median Black household.
So what I'm hearing is that people who have private health insurance tend to be higher income than those with public insurance. But even taking that into account, there are still these large disparities on the basis of race. And so I think we've kind of covered this, but I just, before we go into your findings, do want to make sure we understand, why are income and assets important if you have a high deductible health plan?
Well, the high deductible design relies on consumers having access to cash in order for them to access medical care. And it's to a much greater degree. So if you have a plan with copays, on average for a hospitalization, you're going to pay about $400 in out-of-pocket costs. But if you have a high deductible health plan, that's the kind of care that would be subject to the deductible. So you're paying out of pocket, at least up until the deductible. Likely you're going to have to come out, thousands of dollars. And most American households don't have emergency savings, are, having trouble keeping up with rising prices, for example. So you don't have disposable income for most people. You're going to be dipping into your savings. So those savings matter a lot more in that context.
That's interesting. So I hadn't really thought of it this way, that income is critical for your routine expenses, and but savings are something you can dip into if they exceed that. And the high deductible structure for those who don't have sufficient income, which is many people, to cover those extra costs, wealth actually matters a lot because it's your backstop. And so both of these, both income and assets are important, and having access to those is important if you have a high deductible plan. Well, let's turn to your study. You did look at the income and wealth disparities among people who are enrolled in high deductible health plans. Tell us a little bit about what you learned.
So the high deductible group is a better off slice amongst the privately insured. They could be, attracted to the tax breaks, better able to bear risk. There's a lot of literature that shows that tends to be the case. So, what we found was consistent with that. And even when we just look at those that don't have an associated healthcare savings account, they do have higher income and higher wealth than the overall privately insured population. But the striking thing is that there is a portion of enrollees there that are very vulnerable. So if you have a high deductible health plan, but no healthcare savings account, and you're a low income household, a lot of those people have low assets as well. So Black and Hispanic households in the first quartile of income, so this is under $33,000 in a year, had about $2,000 in financial assets. And that includes checking, savings, and retirement accounts, which you can incidentally withdraw from for hardship purposes. So including all of that, only $2,000 in financial assets for like a quarter of Black and Hispanic households. So it's not enough to meet the family plan deductible under the definition of a high deductible health plan. So white households in that same income group up to $33,000 had about twice as much. So still, that's only about $1,000 more than the family level deductible. So it's still pretty low. And when you look at those with a health savings account, Black and Hispanic households had about, in the lowest income quartile, had about $6,000 in financial assets. That balance includes their health savings account balance. Whites had about $9,500. So even for low-income households, Black and Hispanic households with a health savings account, they would be spending all of their liquid and near liquid assets just to meet a deductible.
And of course, that's just 1 year, right? The deductible resets each year, and you can't draw on the same assets year after year. So if you have a one-time bad event, you're strained, but if it repeats or it turns in to a chronic condition where you have to make those kinds of draws every year, that's a very serious position. Well, I want to go a little deeper into some of the disparities you found and talk about what we might do about this. We'll cover those topics after we take a short break. And we're back. I'm speaking with Dr. Naomi Zewde about high-deductible health insurance plans and their relationship to the racial and ethnic disparities we see in the United States in both income and wealth assets. Before the break, we really got this picture that there are a significant number of people who are exposed to very large financial risk in the event that they need healthcare services because of the design of their health plan. I think what I'm starting to gather as I listen to you is that we keep slicing a higher and higher income group. So if you take the population as a whole, that's a certain group. But then you take people with private insurance, they're a little higher income on average. And then you take people with high deductible plans, they're even higher on average. But even as we kind of move up the income scale, we still see these racial and ethnic disparities. So I wonder if you could sort of go to the end point here and say, okay, if we're looking at the population with these plans, what is the relative exposure to catastrophic health costs for people in white families as opposed to Black or Hispanic families?
Well, I think that we have to understand that these high deductible health plans are going to expose households to a lot of a lot of out-of-pocket expenses in a catastrophic event. And that it's almost like baked into the design of the high deductible plan. So we designed these plans that require households to bring financial assets to bear in order to access medical care. So there's going to be racial disparities in access in a new way. The high deductible health plan design adds something new. So income inequality drives disparities in access through copays. But conditional on income, we have this really vast wealth disparity. So it adds kind of just a brand new layer to the disparities in access with insurance. It's not just this racial disparity. It's kind of just, it's a disparity based on where you came from because of the intergenerational nature of wealth. So really any household that doesn't have that access to intergenerational wealth is going to have trouble with this design. It's just that the racial disparities are so extreme, it makes sense to focus on that.
Right. So when we think of insurance, it is both protecting our income and our assets, right? So you get through the year, you can make it through your year because insurance, you have predictable expenses. That's the whole concept of insurance, and it's a form of income protection. But in a catastrophic circumstance, if you have sort of traditional comprehensive insurance, that's unfortunate, but it doesn't go deep into you needing necessarily to tap your savings. But if you have a high deductible plan, there's a much higher risk that you're going to need to go into your savings, which, of course, is not something that everyone has. So,
so then you'll have the health problem and the money problem.
Right, exactly. So you have the health problem and the money problem. And again, you may have it once, but you also may have it year after year. So I'm trying to understand what you just said, which seems so critical, which is that the high deductible, it's baked in. I mean, it's in the name. And so if the logic of the high deductible plan as it was proposed was make people more price sensitive, is it possible to retain price sensitivity in a way that is not exacerbating longstanding inequities in our country on the basis of race and ethnicity? Or is this just a puzzle that can't be solved?
I actually think that we can do it better. First, just to acknowledge like the possibility for this to really impact our overall healthcare spending in the United States is limited. Consumers are not that good at being discerning about which kind of care that they need. They say cost sharing is like a blunt instrument. Consumers are busy. They don't know. So it's not going to solve all of our problems. We probably still need to deal with prices. And we want to because it's getting harder and harder for Americans to care for their health. So this matters. I think that there is a way that we can do this better, and that's by not relying on households to be the ones to contribute to these accounts. So if we have ways of incentivizing employers or whoever is the plan sponsor, marketplace plans have really high deductibles too. So if the federal government or the employer, usually they pay on average about 80% of the premium, maybe we can target that breakdown for contributing to the HSA as well. For example, maybe an additional tax break if the employer seeds the entire deductible amount into their account. Maybe lower limits on individual contributions so that it can be balanced against the employer contribution, something like that, in which case it could actually help to lift up households who lack assets now.
So what you're describing is a way to preserve price sensitivity in the sense that if I make a wise financial choice here, I get to keep some of the savings. That's sort of, again, what the concept is. But provide that incentive in a more equitable way by not making the exposure to risk so dependent on the accumulation of intergenerational wealth. And this goes back, I think, a little bit to the conception of the high deductible plan as being in conjunction with a savings account, but the reality that not everyone has one. So you did in your research look at disparities for people who did and did not have a savings account. And did you find the disparities were very different?
The main difference between the two groups is that the group with the health savings account has a healthcare savings account. So in terms of like their actual, they're not necessarily different kinds of people so much, in particular when you're looking at the lowest income households who are, going to be the most vulnerable to these policy choices. The difference in their financial assets is a few $1,000s. Which is likely a lot of that has to do with the healthcare savings account itself.
So I love that answer. The difference is they have an account, and that's really all that's there. So if it's like saying, poor people are different because they're poor. So in this instance, what I hear is that if everyone who had a high deductible health plan had a health savings account, then we could really buffer people from at least some of the effects. Now, we can have a debate, and we should, and we do periodically, about whether people can be price sensitive and how much you'd really save from that. You already, I think, explained why we should be skeptical about how much can come from that. But what the implication I draw from your work is, if we funded savings accounts through something other than accumulated wealth, then we could actually significantly reduce the inequities associated with having high deductible health plans. That doesn't answer the question of whether what they accomplish, but at least the inequitable design we could make a big difference in just by doing that. Now, of course, I say just, that's not an easy thing to do, but does that ring true to you?
Yeah, it really does. And I agree. I mean, just, right, is doing a lot of heavy lifting there. But it's true that whatever value we can obtain from consumers being price sensitive is going to run up against the issue of who is making those choices and what resources they are bringing to bear on whether, like, on that decision-making process of should I access this care or not. And so if there's a way to both incentivize consumers to the extent that it's useful to make those wise decisions without necessarily, recreating all of these existing wealth and income and, racial intergenerational disparities, then that seems like, for people who are trying to devise healthcare policy, we would want to try to do that.
Well, that seems like a great place to wrap this up. You've pulled together a lot of threads here. What it really comes down to is, if we rely on consumers to be discerning, we're going to perpetuate racial and ethnic inequities that are based on decades, centuries of history in this country. So long as we see value in consumers playing that role, it should be incumbent upon policymakers to think about how to preserve that consumerism while overcoming the inequities that are baked in. And one way to do that, not the only way, but one that you've set forward here, is to take the saving side of this more seriously and take it out of the circumstances of the individual. And whether that's the way we go or not, what your research has shown a clear spotlight on is how a policy of consumerism that is on its face race neutral actually has quite differential implications for people based on race and ethnicity because of the inequities that exist in our society. And that in and of itself is something we probably ought to pay more attention to, because you don't see the words of race or ethnicity in any of these policies, but they have implications for them.
Yeah, and that's also something to keep in mind, that whenever something does rely on wealth and savings, if it doesn't use the word race, it will have those implications.
Well, Dr. Zewde, thank you so much for the paper, for walking through this complicated relationship across insurance design and our country's history. Thank you for being my guest today on A Health Podyssey.
Thanks so much for having this conversation.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about A Health Podyssey.